All right. Well, I have 8 o'clock or 11 o'clock if you're on the East Coast. Uh, I'm JP Giliberto. I'm one of the assistant professors at the University of Washington. I wanted to talk to everybody about the adverse effects of PPI. Not so much a clinically oriented talk, but I do think it's very applicable, as many of us, especially laryngologists, are either taking people off or putting people on proton pump inhibitors. And I do think it's sort of an exercise on how to critically evaluate, a quagmire of literature, which also can be helpful. And that's sort of how I structured the talk. Because I do have a fair amount of stuff to get through, I'll probably take the questions through either the question and answer as well as the chat when we get to the end after we've gone through most of the lecture, as long as that's okay with everyone. So I initially got into this topic when trying to take an evidence-based approach to assessing the plethora of literature about the risks of proton pump inhibitors. And as many of you know, this was published in the 1990s by McMaster University in Canada, my home country. And they wanted to take a systematic approach to analyze published research as well as form the basis of clinical decision making. So really, if you think of our clinical problem as sort of a road or a way that we're traveling, we use our experience and our training as well as the literature and evidence that we have to sort of guide us along the road to get to our optimal clinical outcome. And this is obviously an idealized fashion, and although this road is straight, often sometimes the literature landscape will look pretty convoluted, and none of the roads will be straight, or you'll feel like you're going in circles. That's loading there. And it can sometimes be hard to get to the right place without actually having a clear roadmap. So I wanted to use this evidence-based architecture to apply to the proton pump inhibitor literature to see if we could make some sense about how to interpret and how to make clinical decisions based off of that. So when we're thinking about evidence-based medicine, there are obviously a number of levels of evidence, and often we want to rely on level 1 evidence. However, sometimes it's just not present, or it's unethical to gather. So we typically will lean on observational data or level 2 evidence to make some of these conclusions. However, these associations that we find in level 2 evidence are not always causation. As you can see by this graph here, it has a significant correlation with an R value of 0.23, but there's clearly no association. It's important that we have some sort of framework or roadmap in order to get through when you have primarily observational data or conflicting level 1 evidence. So how I've approached this is taking the Bradford-Hill criteria and applying for causation and applying them to the PPI literature. As many of you may know, the Bradford-Hill criteria was used by Bradford-Hill to help argue for the causation of smoking and lung cancer in the absence of being able to randomize people to smoking. And the criteria contains 9 different parts: strength of the association, so the effect size. Typically a risk estimate of over 3 or under 0.3 is strong. We want it to be reproducible. We want it to be specific. And in this case, I'll use the lack of confounders or bias in the data as sort of our as a measure of specificity. You want a cause before the effect or temporality. You would like to see a biologic gradient or a dose response curve. You'd like to have some randomized controlled data or experimental data. And then these last 3, plausibility, coherence, and analogy, I'm going to sort of rope into mechanism just to sort of speed along the discussion for today. And that's basically looking at the mechanism. Does it make sense? Do we have analogy or analogous mechanisms? And is there coherence between the epidemiological and the laboratory data? So I'd like to take that framework and apply it to the major risk categories that we'll see, including cardiovascular events, dementia, pneumonia, GI infections, macro and micronutrient deficiencies, chronic kidney disease, and fractures. And this is the chart that I have laid out for us as our roadmap for going forward. As you see, we'll fill it in and it'll help us make some decisions at the end. And then we'll digest that information and try and figure out how we're going to talk to patients about that. So firstly, let's take a look at myocardial infarction. There are two proposed mechanisms by which PPIs can put patients at risk for myocardial infarction. The first is by interference or competition for metabolites through the liver enzyme CYP2C19, which also activates clopidogrel or Plavix. And so we theorize that this competition would decrease the effectiveness of Plavix and therefore put people at risk for myocardial infarction. In addition, there's more of a generalized population a mechanism where PPIs directly inhibit nitric oxide synthase to enhance vascular contractility. So when we look at the data that is in this, when we look at the data, there are a number of studies, but the major ones that I want to focus on are the BAT et al. In 2010. This was a randomized control trial looking at PPIs in clopidogrel patients taking clopidogrel for an acute myocardial event. In this randomized controlled trial, where they were specifically looking for bleeding and cardiovascular adverse events, they showed no hazard ratio increase for these events. And it is some of the best quality data that we have in the PPI literature that argues against a risk for acute cardiovascular event, especially in this very specific population that are taking clopidogrel. This is compared to the observational study, which is which is Shi et al., which looked at insurance data to correlate over 1 million patients in an observational fashion, which showed still a slight hazards ratio in a very, but it's important to understand that when we're weighing this data, that the level 1 evidence seems to argue for a lack of risk. So in this case, we do have some mechanisms that have some evidence, although the best level 1 evidence seems to argue against those mechanisms. These are randomized controlled trials, and there is propensity control matching, which would decrease the amount of bias. However, there still is some present, based especially on these larger insurance controlled papers, which have some misclassification bias. Our strength of association is small. It's under 3 or above 0.3. And there is some inconsistency in the data. I just chose 2 of the studies, but there are many that show a risk for and against. In this case, there was the ability to show temporality, and no gradient was noted. And the biggest con here is that experimental evidence, that level 1 evidence that argues against the presence of a risk of a cardiovascular or MI event. So let's take the similar framework and apply it to dementia. If we look at the mechanisms to how PPI use can lead to dementia, there are 2. First is that it interferes with the B12 uptake, which we'll talk about in just a second. It also impairs the clearance of beta amyloid in some mouse models. Now, this really was catapulted onto the scene as a potential risk in 2016 by the Gom et al. Paper, which was a German observational insurance claims data cohort where they looked at regular and intermittent use, and they noted a dose-dependent response to the risk of new onset dementia. However, they were using insurance claims data, so there was some concerns about misclassification bias, especially in how they considered dementia. Just change my this so I can see things a little better. There we go. Great. So then but there was some concerns about how the paper adjusted for covariates. All of the covariates of drinking, diabetes, hypertension were all associated with the PPI use. And there's no gradient on those papers, and gradient for those you either had hypertension or not. It didn't say if it was controlled or how bad it was and how many medications you were on. So there's no assessment, or for diabetes, there's no hemoglobin A1C. So it's unclear how, if there was adequate adjustment for these covariates in their adjusted hazard risk ratio. So in response to this data, a number of observational prospective cohorts were performed. The best, in my opinion, is the Goldstein et al., which looked at Alzheimer's centers across the United States, and they looked for and they were using regular neuropsychiatric testing to definitively and very accurately diagnose incident cases, which limited the misclassification bias. And in this study, you saw always intermittent PPI use did not show any risk for mild cognitive impairment. That's what MCI stands for, all-cause dementia or Alzheimer's dementia. And there are 3 or 4 other similar cohort studies that echoed those findings. So when we look at the dementia data, although there is some mouse models and basic science data to indicate there is some mechanism support, we do know that there's a lot of bias concerns, especially with misclassification from the insurance data, that sort of make us think that there may be some concerns about the specificity and introduction of confounding bias into the data. Not only that, the biggest concerns are the consistency, as well as the strength of the association, which is actually negative in some of the prospective cohorts. So the best quality data will argue against dementia being a risk of long-term PPI use. In looking at the risk of infections, the base mechanism is the same for both pneumonia and gastrointestinal infections. Hypochlorhydria is, the body's defense against bacterial infections, and it obviously makes sense. And there's a lot of basic science data that supports that hypochlorhydria decreases bactericidal effect of the stomach acid, which leads to downstream infections. There are some authors who say that this same hypochlorhydria leads to change of the oropharyngeal biome and increased risk of pneumonia because of ascending migration of those increased bacterial loads from the lack of bactericidal nature of the antacids for acid suppression. When we're looking at the risk of community-acquired pneumonia, there's a plethora of literature. And I think it's important to really sort of take a couple seconds to parse what we have available to us. If you look at the best quality data from randomized controlled trials, we see that from adverse event reporting, there was no increased risk of pneumonia in those patient groups. However, we are relating on adverse event reporting. We are not, these randomized controlled trials of PPIs were not necessarily, their primary aim was not to assess whether or not community-acquired pneumonia was a potential risk factor. So, it's important to keep that in mind. But there's a lot of evidence within 20 randomized controlled trials that argues against hypochlorhydria as the source of hospital-acquired pneumonia risk. We saw that there was no increased risk for acid suppression in these patients. But it's important to understand that this argues against the mechanism, not just PPIs themselves, because both H2 blockers and PPIs were used for this study. And there is some randomized controlled trials, including some there's a meta-analysis of about 20 studies, including some randomized controlled trials that showed little or no risk, even if it did exist. So in reviewing the data for pneumonia, we see that there is some concerns about the mechanism, which especially with the 20 randomized controlled trials, which argues against the risk. There is some specificity bias, and the strength of association, as well as the consistency and temporality, are not clearly defined in the studies, making pneumonia an unlikely adverse effect of long-term PPI use. For gastrointestinal infections, there seems to be some pretty clear data that there is a risk associated with it, particularly C. difficile infections. There's a number of case control studies as well as cohort studies that have been pooled together in a meta-analysis, which showed a pooled odds risk of 1.51. But it's important to put that risk in perspective when we're talking about the number needed to harm for this study. It was almost 4,000, as opposed to the number needed to harm for 2 weeks of antibiotics for C. diff is about 50. Similarly, if you look at some of the lesser quality data for gastrointestinal infection or gastroenteritis, we had risk estimates anywhere from 3 to 12, depending on the study. So although it's not great quality data, there is some data that suggests that gastrointestinal infections are likely a risk of long-term adverse effects. We see a good mechanism. There's, there is some specificity bias, but it's not overwhelming. There is a good strength of association, especially in some of the gastroenteritis studies. It's consistent literature, although there's not all the studies show consistent temporality, especially in case controls, which don't always have the exposure before the case. So moving on to nutrient deficiencies, we see that B12, iron, and magnesium have been reported. We think that the low acid decreases cleavage and activation of the iron in B12 for absorption, and we think that it's also interferes with the transporter for magnesium. There are a number of case control studies from the Kaiser Permanente group in California that look at huge databases of their patients to assess for exposure that happens before they have a lab which shows that they have a vitamin B12 or iron deficiency. I pooled these results together, although they were not from the same study, but you can see that they have similar results of an odds ratio of 1.65 and 2.49 for both B12 and iron respectively. They also showed, they evaluated a dose response curve by looking at the number of dose categories. Having said that, it's important to understand that these categories look at a deficiency. They don't look at resulting problems like symptomatic anemia requiring transfusions or neuropathy from B12 loss. So they are a lab value, not necessarily a clinical entity, and it is a case control study. Similarly, when you look at meta-analysis of observational studies for magnesium, you see that there's a varied literature, but there is an overall pooled risk estimate of 1.43. Showing a slight increased risk of hypomagnesemia with PPI exposure. And this is for the high quality studies as opposed to all of them together. So the mechanism for nutrient deficiency makes sense. There is some concerns about specificity bias, especially when you're doing these case control studies, looking at huge insurance databases without excellent covariate analysis to really remove any confounders. Risk estimates are still low, showing a weak, not necessarily a strong association. It's hard to really assess consistency. There are not multiple studies like this. And the studies do a good job in this case control models of really showing that the exposure happened before the result. And there is a little bit of a gradient data, but it is weak. But the important thing to understand is this nutrition deficiency, like I said, doesn't always translate into a clinical entity for concern for actual ramifications from the nutrient deficiency. So lastly, or the next two are going to be the ones that we'll probably spend a little bit more time on just because they are a little bit more substantial evidence behind their risks. The first is acute and chronic kidney disease. The proposed mechanism for this is you have an acute interstitial nephritis that leads to an acute kidney injury, and that recurrent acute kidney injury leads to chronic kidney disease. And this has sort of a progression of a number of studies that initially was proposed as a PPI as a cause for AIN, like around when they were initially released in the early 90s. There have been two large insurance and prospective cohort-based studies looking at the increased hazard ratio of both AKI and chronic kidney disease. And then for the Z et al., it was chronic kidney disease as well as progression. So let's take a look at these two major studies on their own to see what we can learn from them. The Lazarus study looked at actual two separate study populations. The first was a prospective cohort that had regular lab values as well as very good note keeping of which medications patients were taking when, limiting sort of the misclassification bias for taking the medications as well as classifying for chronic kidney disease. They also looked at, they took those same study design and applied it to all of the Geisinger-Helsinger data. So they had a prospective cohort of about 10,000 patients and then a large insurance-based system evaluation of about 250,000 patients. They had about 7 years of follow-up, and they saw not only an increased risk of AKI adjusted for covariates, they also showed a dose response curve for twice daily PPI use. They found a similar findings for chronic kidney disease. Again, a slight weak association, but present, and also a dose response curve. They also published their absolute excess risk, which we can use to find our number needed to harm. You can see here that the PPI users had an incidence density of 20 cases per 100,000, per 1,000 patient years compared to 18.3 for the no PPIs. And if you do the inverse of this, this gives you your number needed to harm, which allows you to assess how many patients need to be given the medication so basically your number needed to harm is just the inverse of your absolute excess risk. So it gives you a sense of how much does the burden of the prescribing that medication lead to an absolute risk as opposed to a relative risk, which we're going to spend some time at the later end of the lecture talking about how we convey this difference to patients when we're talking to them. In a similar study, Z et al. Looked at the VA database to find similar findings, but also look at the progression of chronic kidney disease, not just its presence. You can see here they had about 20,000. They had 173 PPI users, and they compared them to H2 histamine receptor blockers, and they noticed an absolute excess risk of 11.3 per 1,000 patient years. Not only did they notice an increased risk of chronic kidney disease, they also noticed an increased risk of progression of the chronic kidney disease, including doubling of the serum creatinine, as well as 30% loss in the glomerular filtration rate, as well as progression to end-stage renal disease. So for the chronic kidney disease, we have a mechanism that makes sense. Although there is some, with these larger insurance studies, there is some concern for misclassification bias, particularly when you're not having a prospective data collection. However, the reason I called it weak plus was chronic kidney disease is one of those diseases that's fairly easily defined by the biometric and lab data. You know, if someone has an eGFR of less than 60, that is their chronic kidney disease. So it is a little easier by lab values to avoid misclassification bias as opposed to something like dementia, which is a little harder to just to do based on ICD-9 or 10 codes. But again, we also have these weak associations, but the data is fairly consistent. In both studies, there was a careful attention to having the dose and the exposure happening before the effect. And we showed a gradient, not only a gradient in dosing, but also a progression of disease while taking the medications. Again, unfortunately, we don't have any experimental data to refute or support this, but all in all, it's a pretty it's not a strong association, but it's pretty consistent in its reporting. The last the last risk or adverse effect I'd like to take some time to talk about is fractures in bone density. And it's important to really take a second to reflect on the mechanism here, because there is some thought that it might inhibit calcium absorption, but there's also some evidence that it can directly inhibit bone-specific proton pumps in the osteoclast, which can lead to disruption of bone remodeling, which leads to bone fragility. Why this is important is because bone mineral density has always been used as a surrogate marker for fracture risk. It's easily reported and seen in these large prospective studies. However, it's important to understand that this second proposed mechanism unlinks density from fracture risk. So if you look at the data, the major longitudinal studies have failed to demonstrate an association between PPI use and osteoporosis, but there have been a number of meta-analysis of observational studies that show that there's an actual risk of fractures, even though the bone mineral density does not necessarily change. So for bone density, there's a number of studies. The one I want to spend some time talking about is the SWAN cohort, which compared pre and postmenopausal women on PPIs versus H2 blockers. They had annual follow-ups of bone mineral density for about 10 years, and there was no significant association between PPIs and bone mineral density loss. This has similar findings to a number of other studies which showed no significant risk of bone mineral density change, and they had very similar, some of them were even larger studies, although they weren't as frequent in their bone mineral density assessments, but very consistent data that PPIs do not affect bone mineral density. However, if you look at some of the best data that we have for fracture risk, this is a meta-analysis of 9 case control and 9 cohort studies. We see that there is pretty significant and consistent risk of any site fracture, which is over here on the right, or hip fracture over here on the left, or spine fracture. And when you look at the various specific other meta-analysis that have been reported on risk of fracture, you see pretty consistently that long bone fractures like hips, spine, are consistently show a mild association with risk or relative risk, whereas wrist fractures are the only ones that don't show an elevated risk in any of these meta-analyses. So again, the mechanism seems pretty logical, and there's some data to support that it's true. There may be some specificity bias. A lot of these studies are case control or observational studies that don't have, that aren't prospectively, are sort of a retrospective observational study. There's a weak association, but they're pretty consistent in their reporting, and they do, the studies do a good job of showing the temporality of the exposure of the PPI before the event. So in taking this sort of colorful heat map, how do we break it down into what we think is true and what we think is not true? And I think that it's pretty safe to say, based on the data, that cardiovascular events, dementia, and pneumonias, there's pretty good data to suggest that they're not a causal relationship. Particularly for pneumonia, we saw the mechanism is questionable, and the randomized controlled trial, argues against the risk as well as the mechanism. And for cardiovascular data, the best quality data that we have shows that the increased risk is not necessarily there. And then for dementia, we saw that the later, better quality observational data argues against any risk. For some of the other relationships, we've already touched on some of these topics. We've talked about how C. difficile and gastroenteritis have some, the C. difficile has some good data. This gastroenteritis has case control data only, but a lot of these risks are very weak, and their number needed to harm, or their absolute risk estimate, is fairly small, especially when you take a consideration of C. diff, which, as I said before, requires a 50, has a number needed to harm of 50 for someone who gets 2 weeks of antibiotics. Now, these infections, excuse me, the micronutrients and the gastroenteritis and the C. difficile, I mean, these are unfortunate when they happen, but the micronutrients and gastroenteritis can be pretty easily correctable, as well as the C. diff with antibiotics. It's these fractures in chronic kidney disease that are fairly concerning. And even though we only have fair data, there's no randomized controlled data to support its use, it's important to keep them in mind when we're talking about when we talk about patients. So, I think it's important that we just spent half an hour talking about reviewing probably 20 or 30 different studies. So how do we then break these studies down into a conversation that fits into a 15 to 20 minute new patient or follow-up visit? And I think these come up fairly frequently, and often patients have their own sort of reading and information and thoughts on the process. So I typically, if I'm ever starting someone on proton pump inhibitors or broaching the discussion about acid suppression, I always want to acknowledge their findings and not dismiss them as being unfounded or not true. I then like to express some quality about the data concerns. I like to tell them that for cardiovascular events and pneumonia, as well as dementia, that the best data that we have argues against any risk. And then for chronic kidney disease, fractures, and nutrient deficiencies, the absolute excess risk is pretty small. And I have a little lottery analogy that I'll take you through in a second. And then I like to tell them that I take that risk seriously and I don't want them to stay on these medications forever. So unless there's a good reason. So I have this sort of cheeky little thing that I did. I swear no MAs were harmed in the making of this little diagram here. But so this is me talking to one of my MAs, and this is almost word for word what, I bet you a bunch of my residents could repeat this verbatim for me. But first thing I'll say is, yeah, you are right, or you may have heard. There have been a lot of concerning press and even scientific publications about the risk of those medications, PPIs, but the data is not great. In fact, concerns for dementia, pneumonia, heart attacks, the best data we have argues against, may suggest that there may not even be a link. For others, like kidneys disease, bone fractures, gastrointestinal infections, and micronutrient deficiencies, this data is still not great. And it's important to consider that 25 to 50% increase of a rare event is still quite rare. Take, for example, if we both play the lottery, you buy 2 tickets, I buy 1, your chances of winning are 100% greater than mine. But we both know that each of us is showing up to work next week. I'm only half joking, because even though the risks are small, they may be the events are significant and when they do occur. So we need to take putting you on these meds seriously. So I don't want you to be on them forever unless you demonstrate you need to. So in 3 months, we'll just try to stop or change these medications to another type that we think is safer for long-term use. So that's what I say. I do have a little smart phrase for those of you who know me, know that I love EPIC. So I have my own little patient education information, along with a patient array, which is sort of a tool which is helped in shared decision-making to help patients understand absolute versus relative risk. And then, so this is 1,000 patients, and this is taken from the chronic kidney disease literature. And we can see here are our 18 cases of chronic kidney disease in the general population. I have then circled the 1.7 or 2 cases that are associated with use of PPIs. And so it helps patients understand that the risk of the event is small, and a 20% increase of that risk is still rather small. And so I will often bring this up in the room and go over with them if people have concerns. For my own management, if I do feel like somebody has something that is related to reflux, besides diet, I will recommend 3 months of an H2 blocker at night, 40 milligrams PO daily in the morning, and then sodium alginate therapy, either Reflux Gourmet or Gaviscon Advance. And then we will DC or transition to discontinue or transition to H2 blockers, and we for about 2 weeks, we'll go every 48 hours on the PPI to avoid the rebound effect. If patients do talk to me and say, I'm concerned, I really don't want to be on these medications, I will offer them an alternatives to do just the H2A blockers first, and even now doing pH testing up front. Obviously pH testing is a whole other lecture about the different kinds, but there is some data from Tom Carroll in Boston that this may be actually more cost effective if you can get people to sign up for, a nose hose for 24 hours. I will consider pH or impedance testing upfront if the patient requests, if I'm concerned about the diagnosis or if it's in question, or if we're considering an anti-reflux surgery referral to help speed the process along. And then will I use PPIs long-term? Rarely, but not never. We need to have a very specific indication. For instance, I have a couple of cough patients that have a positive pH test that respond to PPIs 40 milligrams a day. And if they come off of it, their cough comes back. So, we can talk about the risks of keeping them on those medications long-term versus them, the risk of the operation, or with the suffering through the symptoms of the cough itself. So, these are all lengthy sort of patient conversations, but and every patient is specific. There's no cookie cutter way to approach it, but those are just some pearls from how I will either start or transition patients off proton pump inhibitors. So thanks a lot for, that's what I have prepared, but I did want to take a couple of seconds to sort of reflect on this really odd and trying time that we are all going through. It's amazing how life-changing events, I just had a little baby girl just before this all started, really sort of reorient your priorities. And I think that although I don't necessarily have an answer for all of the anxiety and life-changing events that are taking place for everybody's in everybody's life, I have noticed for myself that taking joy in the small little wins, like getting my daughter to laugh or taking a funny picture when she is wearing a hat, can be pretty helpful to really help center yourself in what's important. So, I really feel that that gratitude can be really helpful antidote for a lot of the stress and anxiety and upheaval and change that are happening in people's lives. I do think that I'm not only grateful for my wife and my family, but also my co-chief residents here. And I'm not just showing this because it's the UK. I'm not pandering. This was our PA. She was a UK fan. I'm not pandering. But this is our chief class. We all still talk and get together once a year, and it sort of speaks to the fact that I feel very lucky that we are able to practice one of the best specialties in medicine. And although that might change in the future, I think that efforts by the Kentucky faculty and Dr. Comer, et cetera, to put on these national education programs means that we're going to persevere. We're going to find new ways of doing things, and I think that in the end, we'll look back and hopefully we can look back at some of the great things that people did and say it made our specialty better. So, and with that, I'll take some questions.
Thank you, JP. That was wonderful. And your little daughter is beautiful, by the way.
Thanks. Yeah, she's kind of fun. So I didn't see, where's my chat questions? I don't have any questions. Is the chat open? Chat. I don't have any necessarily questions on chat. Does anybody want to speak up or have any questions in the Q&A for me to review?
I'll bring one up actually to you. I'm a rhinologist, not a laryngologist, so I gotta give that stuff
Yeah.
to Fritz. But you thus far related to the PPIs or other reflux medications, have you run into any questions from patients thus far you just haven't been able to answer very well? Because I thought this was a beautiful talk to cover. I mean, it's a challenging subject. I mean, trying to compile all that information.
Yeah, no, it's tough. You know, people will always come in with their predetermined sort of biases, and I try to respect those and not shoot them down. You know, people will say, "There's no matter what, you're not putting me on those medications. I don't care how long you talk to me about the data being sort of questionable or just a short term." And I work with those patients. We say, "Well, we'll try and really, you know, we'll really get into the diet and the habits, and we'll set them up for a laryngeal hygiene visit with our speech pathologist to really focus on." Um, changing what they can in their diet, and you know, we'll take the behavioral frame of things. Or sometimes you know, patients will be like, "Well, I'm not going on it," and then I'll say, "Well, let's get you tested just to know whether or not it," you know, because sometimes we use PPIs as a therapeutic trial. Well, and then that'll sort of leverage me into saying, "Well, why don't we get you tested so we know that your cough is not, your nocturnal cough when you lie down after you have spicy food is not due to, you know, to acid reflux," and that can sort of help if they sort of not refuse, but if they sort of butt up against that sort of you know, empiric trial, then we can sort of help us, you know, help them buy into getting a nose hose for 24 hours to get acid reflux testing. So.
Very good. Looks like you got a comment and then a question. Are you able to see those? Or?
Yeah, I got the how long can you give a PPI for LPR? So I think a lot of that, thanks Red for the question. I think a lot of that really depends on if you have symptoms that are responsive to the medications, and how bothersome those symptoms are. You know, my typical empiric trial is 3 months, and if people aren't getting better, then you shouldn't keep them on it unless you have some other reason to think that they're, you know, that they need to be on alginate therapy, or they haven't been doing dietary modifications or something like that, to think that you still need to keep them on PPIs. But like I said, I have some patients who have pH positive testing for cough, and you know, they've elected to stay. They're what, you know, 70s, 80s. They don't want to get a lapnicin. They want, you know, they don't think that their symptoms are long enough, and they're willing to accept some of the risks, especially when we talk about the fact that there is a slight increased risk, and the fact that people, you know, there are risks of you're balancing the risks of the long-term medications with the risk of the operation. So, you know, like I said, you want to, if you have put someone on PPIs, you want to have an end date, or at least an attempt to trial to come off of it or transition them to H2 blockers. But like I said, if they demonstrate a need for long-term care, then I don't think we should throw the baby out with the bathwater, as they say, by you know, saying that these medications are too risky long-term. Was there a comment? Where's my chat? Yeah, great. If anybody needs to, or is in Epic and wants my Epic smart phrases, my email, I should put my email up there. It's jpgent@uw.edu. Just my initials, and I'm an ENT at UW. I'm happy to send over some of those. And there's a number of those array makers online. I think the one I used was from the University of Michigan, and they can help you make ones for various shared decision-making tools that you may be wanting to employ at your various institutions. So anyways, I think that's it, unless there are any other questions. Thanks again so much for allowing me to do this. It always makes me heartened when our specialty comes together and does these impressive projects for the better of education and for our future colleagues. So
Well, thank you again, JP. That was just absolutely outstanding talk. I thought that, and it's not even within my subspecialty, so I thought that thanks for joining us. Thank you for everybody out on the West Coast for supporting this initiative as well. I know it can get a little early sometimes in the morning.
That's why I got the last slot, because anything earlier than 8 o'clock for PPIs is just too early. So,
all right.
Take care. Okay. All right. Thanks, everyone. Bye. Take care.
For those who are listening, let's go over our lineup for tomorrow morning, Wednesday, the 22nd. So we're going to start out with laryngology talk on care of the professional voice by Sandy Archer from here at UK. The 9 o'clock hour will be Dr. Argenbright from Kansas University. He's going to talk about velopharyngeal insufficiency evaluation and surgical management. The 10 o'clock hour will be Dr. Marati from University of Washington with careers in otolaryngology, so kind of a business of medicine type lecture, which I think that's important that we've incorporated in this consortium. And then the final one of the morning will be Dr. Liu from the University of Washington, talking about management of flaccid facial paralysis. So again, thank you to everyone for listening. Spread the word to other residencies, and we will talk with you tomorrow.